Will's right about this choice. When I was given my title, I felt a little bit like the toothbrush, but actually when I looked at the other titles lectures you've been put through today, I realised it maybe wasn't that bad. So my plan is to give you a very logical talk through the different types of bugs you need to know about, and then a little bit about the medicines we use to treat them. The first proviso that you need to know is I am not a microbiologist, okay? I'm a respiratory paediatrician, and therefore I'm going to teach you very much at the level I think you need to know to pass the exam, and this isn't a high-flying scientific lecture. So we're going to start off looking at viruses, and the first thing that you know that's pretty obvious is that they're very small, okay? So they're small, you can't see, so much so that you can't see them under the light microscope. But what I'll show you in a minute is actually what we can see under the light microscope is some of the effects of those viruses. But you can't see the virus themselves. The most important thing about viruses is that actually they are completely unable to synthesize energy themselves or to make protein. So they're totally dependent on the host cell to replicate. Once they do go through that, and I'll show you a slide about how they replicate, the viruses can replicate quite quickly at a rate of a number of hundred per hour. So a reasonable rate, but when you talk about bacteria, you're talking about thousands per hour. So they can't replicate at the rate the bacteria can. The classification of viruses sticks to 4 very simple things about the virus structure. And I'll show you a diagram of this in a second. But the first thing you need to know about the structure of viruses that is key to the classification is that they have a core of nucleic acid, and that can either be RNA or it can be DNA. Around that core of nucleic acid is a protein coat that's called a capsid. And that capsid is made up of repeating subunits, helpfully called capsomeres, and basically the capsomeres determine the virus's symmetry. And that's one of the classifications of viruses, whether they're RNA or DNA, and then they talk about the symmetry, and that's dependent on the capsid. The capsid is also involved in the attachment to the host, and it's probably the capsid that's it's involved in inducing the host immune response. So that's the first 2 things about structure. The second 2 things about the structure of virus that you need to know that's key, is whether they do or don't have an envelope. So that a lipoprotein envelope is derived from the host cell membrane. So they don't have it when they go in, but when they go into the host cell, they can develop this lipoprotein envelope. And rather the other way around to the way you'd think, but actually if enveloped viruses are actually unstable. So if you have a virus that has an envelope, such as RSV, are much less stable, and therefore when they go outside of the host, they're very easily inactivated by things like the alcohol hand rub that we use, or simple detergents. Now that's in contrast to viruses that don't have envelopes, like the Norwalk virus, and actually they're very difficult to eradicate from the environment. So in terms of the envelopes as viruses go, those that don't have the envelope are much more difficult to get rid of. And then on the absolute outside of the viruses is an outer layer of glycoprotein spikes that help you aid attachment to the host cell. And so when you look at a virus, this is what you look like. So those things we mentioned. So you've got the nucleic acid that is not contained within the nucleus. You've got the capsid around it. You may or may not have a lipid envelope, and then you've got your glycoprotein spikes to actually involved in attaching to the host cell. So that's all there is to the structure of viruses. And if you know about the structure of the viruses, you can classify a virus, because it's classified according to those simple 4 things in the structure. As I've said before, replication of the virus, it has to be taken up by the host cell. So this is a diagram in relation to influenza, but it could be any virus. And basically, as you can see, the first stage is that the virus attaches to the cell. It's then the cell will engulf the virus by endocytosis. The viral contents, so the nucleic acid from within the virus are released and incorporated into the host cell's nucleus, and it basically makes the host cell produce the viral proteins and then produce the virus. So the virus gets into the host cell and then makes the host cell do all the hard work in terms of producing it, of the reproduction. And as I said, and it can produce hundreds of viruses per hour by doing this. Viral infection can have lots of different effects, and the different viruses can do many different things, and that's probably and the effects that they have vary between the different viruses. So the most obvious thing that it does is when the virus infects the host cell, the cell can die, and it does that because actually, although it will encourage or allow viral protein synthesis, it stops the cell producing its own proteins, and therefore the cell dies. And you may well see that effect. So again, when we're talking about the fact you can't see the cell under the light microscope, you may well see the effect that all the cells that it infects are dying. And that's called the cytopathic effect. So the structural changes in the host cells caused by that invasion due to cells dying. So the second thing that you might see under the light microscope, but that you, as an effect of the of viral infection, is it actually causes the host cells to fuse. So rather than having single nucleated cells, the host cells fuse, forming multinucleated giant cells. And RSV is classic for doing this, and I'll show you in the next slide an example of that. The third thing that viruses can do is it can cause malignancy. So we all know that human papillomavirus is associated with cervical carcinoma, and it does that by instigating unrestrained growth, prolonged survival of the cells, and morphological changes. So basically, it stops the cell dying, and it makes the cell increase the number of times itself is being replicated. If we go back once to talk about the second point I said, talking about the giant multinucleated cells, this is with RSV infection, so you can't see the RSV, but you can see this giant multinucleated cell. That's a direct effect from the RSV infection. And so that, again, is just seeing the effect of the virus, but not being able to see the virus itself. Other ways that viruses can be pathogenic, you can get chronic carriage of the virus. So this actually where viral replication will continue without it killing the host cell. And hepatitis B is a really good example of this, where you will continue to produce the virus, but the host cell will remain intact. And hepatitis B is actually probably due to the inflammatory response to the viral antigens on the host surface. The final thing that can happen is basically latent infection. So basically, the virus goes into the cell, but it doesn't replicate, but it stays there. And herpes is a good example of that. So we all know about shingles and chickenpox, so that's exactly what happens in that situation. So you have chickenpox. When you go into the latent phase after the primary infection, it can stay there for a long time without causing any problems, and then subsequently be reactivated, causing disease. So that's the latent infection you can get with viruses. So most of the things we need to think out relate to cell death, but we need to be aware of those other ones with specific examples. So that's enough about viruses. So I'm going to talk a little bit about bacteria. Now, I think if I'd have seen this question when I was at your stage in this clinical exam, I would have slightly lost the will to live. And I would probably have just skipped on to the next question, because I didn't really know about it. And I don't know, you may know the answer to that, but I hope what I'll be able to do in the next 10 or 15 minutes is give you a very clear way, logical way, to be able to answer that without any problems. So have a think about what you think the answer is now, or write it down as to what you think it might be. And then we'll move on and we'll come back to that question shortly. So, just like I told you about about viral classification, in how the structure of the virus enables us to classify it, it's very similar with bacteria. So the first thing we need to think about when we classify bacteria is whether they're gram-positive or gram-negative. And I think I certainly, at your level, probably didn't have a very good understanding of what gram staining was. And so in a minute, I'll talk you through that process, and then we'll talk about how the structure of the gram-positive and gram-negative bacteria cause the differences that we see between the two. So that's the first stage of bacterial classification. The second thing we need to think about in classifying bacteria is what shape they are. Okay, so we're not talking rocket science here. And there's only three options, okay? They either look like blobs, i.e. cocci, they look like rods, so the bacilli, or the wiggly line and the spirochetes. Okay, so again, not rocket science. If you have cocci, it can grow in different ways. So the arrangement of cocci is also very important. You can get clusters, as you do with Staph aureus. You can get chains, as you do with Streptococcus, or you can get pairs, as you do with Neisseria meningitidis. And again, that's pretty simple, but again, if we go back to that original, think about that original slide that we looked at, and this is suddenly starting to become a little bit clearer. So the first two stages of bacterial classification. The third thing we can think about with the bacteria is what their growth requirements are. And basically, that's whether they like oxygen or they don't like oxygen. If an organism is an obligate anaerobe, it means they have to have oxygen to grow. And if you cut have that oxygen supply, they will die. A facultative anaerobe is those that prefer to grow in oxygen, but actually can still generate energy when that oxygen stops being, or when the oxygen levels reduce. And an anaerobe, in contrast, is something that will only grow if the oxygen is low, and that's normally less than 20%. The final stage of bacterial classification is about the production of spores. So some bacteria produce spores. So under stress, and it's basically a survival mechanism. So certain bacteria, if they're exposed to toxic chemicals or heat, will basically produce spores as a way of surviving, because they know that that heat or those chemicals is going to kill the bacteria, and those spores can actually then survive for long periods of time, and enable it to regrow at a subsequent time when conditions are more appropriate or more suitable. So, gram staining. Coming back to that very first thing. We talk a lot about gram-positive and gram-negative bacteria, but actually I think it's something that we probably know, it can be easy to not know a lot about. It's a very simple process, and we've been doing it with bacteria for a huge amount of time. And it's basically 5 very simple stages. So the first thing you do with bacteria are you heat them, and it's called heat fixing, because basically you want the bacteria that you're looking at on your slide to stay in the same place. So you kill it with heat, and when you do that, they stick to the slide and they don't move. Okay, that's all it is. You then add crystal violet, which is a type of dye, and then you add iodine to the slide as well, and that's because the crystal violet and the iodine forms a complex. You then wash it with alcohol, which may or may not remove the purple dye, which I'll explain in a minute, and then you counterstain with a red dye. Okay, so if you remember that process, then we're going to now talk about the structure of the cells and talk about how that would mean that you can differentiate between gram-positive and gram-negative bacteria. Just like we're talking about with viruses, the nucleic acid in bacteria are not enclosed in a nucleus. So basically, the bacterial structure, you have some cytoplasm that's surrounded by a cell wall, and within that cytoplasm, you've got a load of DNA that's just floating around. The DNA is basically a single chromosome of circular DNA. Okay, where so viruses you can have RNA or DNA. In bacteria, it's straightforward, a single chromosome of DNA. And then you have, in addition, also in the cytoplasm, you have other elements that help you produce proteins or produce energy. So you have ribosomes, for example. And as we can see, the most important thing we need to think about, or one of the most important we need to think about, is the structure of the bacterial cell wall. So we're going to come back to a difference between gram-positive and gram-negative bacteria. Gram-positive bacteria have a thick peptidoglycan layer and no outer membrane. Okay, so thick peptidoglycan, no outer membrane. During the gram staining process, the crystal iodine complex goes into the peptidoglycan layer. Okay, that's where the crystal violet stain sits when you gram stain something. So when you've got a really thick peptidoglycan layer that you have in gram-positive bacteria, the crystal iodine complex sits in that thick peptidoglycan, and when you try to wash it out with alcohol, you can't. Okay, so you know, violet iodine, it's purpley blue, so therefore if you've got gram-positive bacteria, they stay purpley blue, okay, when you stain them, and they don't take up the additional counter stain that you add. In contrast to gram-positive bacteria, the gram-negative bacteria have a very thin peptidoglycan layer, and they do have an outer membrane. We'll talk about the importance of the membrane in a second. So in this thin peptidoglycan layer, you do get the crystal violin iodine complex goes into it, but it easily washes out with the alcohol. Okay, so the purple stain that you put in the gram staining process is washed out in the stage 4 that we talked about in gram staining. And because it's washed out, when you then add the red counter stain, it will take that up, and so gram-negative bacteria will appear reddy pink, in contrast to the purpley blue of the gram-positive. Okay, so things you need to remember are gram-positive ones, so you've got thick peptidoglycan, purpley blue. You've got gram-negative, so you've got thin peptidoglycan, they've got an outer membrane, and they turn reddy pink. Other things and other differences on the surface of gram-negative and gram-positive bacteria affect how they react and affect how they respond to antibiotics. So the first thing you may know about with gram-negative bacteria is they may have beta-lactamase within the periplasma space. So beta-lactamase, as you will know, will degrade beta-lactam antibiotics, and so gram-negative bacteria such as Haemophilus influenza may well not respond to beta-lactam antibiotics. Gram-positives tend not to produce beta-lactamase. The surface of gram-negative bacteria may also contain other compounds, and an important one is lipopolysaccharide, which is an endotoxin which can induce septic shock. Okay, so the septic shock that you may associate with gram-negative bacteria is related to the lipopolysaccharide that is on the cell surface. Gram-positive bacteria tend not to have the beta-lactamase. They can also induce septic shock, but that tends to be due to the teichoic acid that they have on the cell surface as well. Bacteria are extremely good at avoiding being killed, okay? And they have many and varied strategies for doing that. We spoke with some bacteria are surrounded by a capsule, by a polysaccharide capsule, and you'll have heard of encapsulated bacteria. And good examples of these are strep and Neisseria and the other ones we've listed there. Encapsulated bacteria are able to evade phagocytosis by standard cells, and actually we rely on the spleen to remove the majority of those bacteria. Because of that, if your spleen doesn't function properly, i.e. in sickle cell, you're much more susceptible to infection by those organisms. So if you're hypersplenic, you're prone to infection with encapsulated organisms. The other thing that you may need to just be a little bit aware of is about biofilm formation. So when bacteria reach a certain quantity, whereas bacteria initially, infection occurs in a planktonic phase where they're kind of floating and moving around, they will then basically become enmeshed and non-motile, so they attach to each other and a surface within a matrix, and that's basically called a biofilm. And when bacteria form biofilms, they are much more difficult to treat and often totally resistant to treatment. So, if we come back to the slide or the question that I showed you right at the beginning, of the two bacteria that we can see on there, what can you tell me about the purple ones? What shape are they? Yeah, So clusters of cocci. So what we said is a good example of that. Staph. Yeah, so this one's probably staph. What's this pink one? So they're bacilli, yeah, so rods. And what, is it gram-positive or gram-negative? Yeah. So, with a relatively little bit of knowledge, we know that's the answer, and that's basically because we've got one of them's a gram-positive cocci growing in clusters, and one of them's a gram-negative bacilli, so that fits with the two that's there. Why can't it be the other ones? Well, it's not going to be strep because that would tend to grow in chains, although the E. coli was obviously correct. Staphylococci was right, but as Listeria, they're both gram-positive, so it wouldn't be that. E. coli and Pseudomonas are both gram-negatives, so we know we've got one of each. And the bottom one are both cocci, or there is one positive and one negative. So with relatively little information, if you know about how you classify the bacteria, it's quite easy to work out what seems like a quite difficult question. So, moving away from bacteria classification and structure, the transmission of bacteria can obviously occur across multiple systems. So it can be, respiratory, gastro, urogenital, or across the skin. For any infection to occur, the bacteria need to attach to a surface, and that is facilitated by pili and surface proteins that are on the bacteria. We talk about the host being colonised with infection, or they're being colonised by bacteria, or having chronic infection once a population of bacteria becomes stable. And you need to be aware that actually different strains of the same bacteria can have quite different virulence or patterns of infection. So, we've spoken a little bit about viruses, a little bit about bacteria. So, in contrast to viruses and bacteria, eukaryotes basically have their DNA within a nucleus. Okay, so this is different to what we've spoken about previously. And I'll very briefly, because I think this is pretty small print, but just talk very briefly about the three eukaryotes, which are protozoa, fungi, and helminths. So protozoa are single-cell organisms that exist in a wide range of environments. They have cytoplasm surrounded plasma membrane. As I mentioned before, their DNA is within a nucleus. They're pretty small print, but there are three main groups that can cause disease in humans, and they are the ones that are listed there. So you have spore-forming ones like Toxoplasma, flagellates like Giardia, and amoeboid ones. I've not spoken about the treatment of these. We will talk about the treatment of the other groups shortly. Fungi are probably a little bit more important. We'll spend a little bit more time talking about it. So things you need to know about fungi. The first thing is they so they live purely on dead or decomposing matter. Okay, so that they rely on that to live, basically. In contrast to bacteria, so we spoke about gram-positive and gram-negative bacteria having peptidoglycan in the cell wall. Fungi don't have peptidoglycan in the cell wall. So lots of the antibiotics which target the cell wall, as we'll talk about in a minute, and target that peptidoglycan layer, have no effect on fungi. What they do have in their cell wall are ergosterol and beta-glucan, and it's those that are targeted by antifungals, and we'll talk about that in a second. Most fungal infections are superficial and basically limited to the skin. Okay, and it's only usually if there's some level of immunocompromise that you'll get systemic fungal infection. And again, that's important to remember. There are three groups of fungi, which really are kind of two and then one that can be either of the above. So the first one is yeasts, and so we all have heard of Candida. So these are very simple unicellular organisms that reproduce by asexual budding. So about as simple as a cell can get. You then have the more complex fungi, which are molds. Good example of this is Aspergillus. So they tend to grow as long filaments. They have hyphae, and the hyphae that they produce help them to gain nutrients from their surrounding and also aid with their reproduction. And some molds will produce airborne spores. And a good example of that is Aspergillus. So they actually produce spores, and once they're in the air, these can then be breathed in. And so if you do have an immunodeficiency, actually you can then get respiratory infection with Aspergillus. Dimorphic fungi are a bit of an odd group who basically can look like either a yeast or a mold. So they tend to take the form of molds at room temperature and yeasts at body temperature. The final group of eukaryotes that you just need to be kind of aware of are helminths, and this is the opposite end of the extreme in terms of these are very complex, multicellular, and they're parasitic worms. They have complex life cycles and they reproduce sexually. The classification is they can either be roundworms, such as nematodes, or flatworms, and the flatworms can then be further split down into flukes and tapeworms. I don't think you're going to be asked huge amounts about the life cycle of the different helminths, so I've therefore not gone into the details of those. So, we'll go on to have a little bit, knowing what we know about the structure of viruses, fungi and bacteria, we're going to talk a little bit about how antibiotics and antivirals and antifungals work. So that's your first question, and again, write down what you think the answer is, and then we'll go through some more relatively straightforward points and see if it enables us to take the answer a bit more. So we're going to talk through some quite logical steps to hopefully make this question much easier. In terms of antibiotic groups, there are lots of them, okay? And I think the things you need to know, so the biggest group is the beta-lactam agents. So these all have a beta-lactam ring, and included within beta-lactams you have penicillins, so things that we use all the time like amoxicillin and flucloxacillin, penicillin and piperacillin. They also have the cephalosporins and also the carbapenems, and in the carbapenems you have imipenem and meropenem, so slightly less commonly used antibiotics. You can have macrolides, so anything that, so azithromycin, clarithromycin, erythromycin are all macrolides. There are tetracyclines, a good example is tetracycline itself or doxycycline. We have the aminoglycosides, the glycopeptides such as vancomycin and teicoplanin, and then the fluoroquinolones such as ciprofloxacin. So it seems a load of different antibiotics, but actually you can actually group them according to how they work, and it tends to make the differentiation or grouping them much more straightforward. The first way antibiotics can work is to disrupt the bacterial cell wall. If you do this, if you basically make the bacterial cell wall stop working, the bacteria dies by osmotic lysis, and therefore this mechanism of action is a bactericidal. So actually it's killing the bacteria themselves rather than just stopping them replicating, it's wiping them out. And that's an important differentiation from the other mechanism of actions I'm going to talk about in a second. So how do we disrupt the bacterial cell wall? Well, beta-lactam and glycopeptide antibiotics do this by preventing the cross-linkage of peptidoglycan. So we spoke about before about peptidoglycan has that thick layer in the gram-positive bacteria and the thin layer in the gram-negative bacteria. That is a key target for beta-lactam antibiotics. It stops the glycopeptide, sorry, it stops the cross-linkage of the peptidoglycan, stops it working, the bacterial cell wall falls apart, and the bacteria die. Within this group, we said you have the beta-lactams contain penicillins, which are mainly active against gram-positives. We'll talk about that in a second. And then we also have the cephalosporins, which can have action against both, and the glycopeptide antibiotics. And they are only active against gram-positives because they can't get through the outer membrane of the gram-negative bacteria. So if you think about how we spoke at the beginning about the gram-negative bacteria having an outer membrane and the gram-positive ones not doing, that membrane directly stops some antibiotics working. Okay, so that's a defense mechanism of gram-negative bacteria, and the glycopeptide antibiotics, for example, can't get through that outer membrane that gram-negative bacteria have. The next mechanism of action is antibiotics that stop the bacteria synthesizing proteins. So when you do this, you stop the bacteria being able to replicate, and therefore they talk about this being bacteriostatic, okay, as opposed to bactericidal. There's a whole group of antibiotics that do that, so the aminoglycosides, macrolide tetracyclines, and basically they all do that at the ribosome level. So they bind to the ribosome and basically stop it being able to produce the protein. Because of the way they work, they have a wide spectrum of activity across both gram-positive and gram-negative, and when we talk about the macrolides, which we'll do in a second, they have a very similar group of action to penicillins, but also cover other organisms like mycoplasma, mycobacterium and chlamydia. So that's a wide group of organisms that this mechanism of action will enable you to be effective against. The third way, so we've spoken about attacking the cell wall, we've spoken about stopping you being able to synthesize proteins, and then we can stop the bacteria being able to the DNA replication. So again, it's stopping the bacteria from being able to replicate. So again, we talk about this being bacteriostatic. Good example of this is ciprofloxacin. Ciprofloxacin is a fluoroquinolone, and basically it stops the coiling and uncoiling of DNA within the bacteria, and therefore stops the DNA being replicated. Cipro, for those of you who've come across it, will probably seen it being used to treat things like Pseudomonas, which is gram-negative, and it's got relatively little effect against gram-positive organisms. The final mechanism of action, the fourth mechanism, is it can actually interrupt chemical pathways. There are various examples of this, but I think probably the best one to talk about is trimethoprim. So trimethoprim inhibits folate synthesis, which you need to form DNA. And again, because it's affecting DNA replication, we therefore say this is bacteriostatic rather than bactericidal. Trimethoprim, as you know, is active against gram-positive and gram-negative organisms. So, when we come back down to this question which we thought about before, we asked you before, so which of the following antibiotic mechanism of action is related to inhibition of bacterial protein synthesis? So, we agree that it's azithromycin. So azithromycin is a macrolide, and we said before that macrolides as well as aminoglycosides work by inhibiting protein synthesis. It can't be amoxicillin or ceftriaxone. They're both beta-lactams, and we know that they directly attack the cell wall by inhibiting cross-linkage in peptidoglycan. Cipro we've spoken about is all related to the synthesis of DNA through affecting its coiling and uncoiling, and trimethoprim is the true to its impact on folate synthesis. So with relatively few key bits of knowledge about how antibiotics work, you can kind of work through what seems like quite a complex question. I'm very briefly just going to talk in a little bit more detail about the different groups of antibiotics and key things that you need to know. We use loads of penicillins. You'll all have had penicillins. They're very good at treating gram-positive infections. And if you think about the ones that we tend to use, so we use amoxicillin, which is first line for chest infections, for lower respiratory tract infections. Penicillin V is used as first line for tonsillitis. And we do that because amoxicillin is associated with a rash if that tonsillitis is actually caused by glandular fever and not by a bacteria. Co-amoxiclav is interesting. So co-amoxiclav is amoxicillin clavulanic acid. Clavulanic acid is actually an anti-beta-lactamase. So that enables us to use co-amoxiclav to treat organisms like beta-lactam producing Haemophilus influenzae that wouldn't be sensitive to amoxicillin on its own. The main problem with penicillins is hypersensitivity reactions. Okay, so allergic reactions, and when you know, from a clinical point of view, what people report allergic reactions might not be, but true allergic reactions occur probably between about 1 and 10%, with a fraction of that causing anaphylaxis. But it definitely can occur, and we need to be aware of it. Cephalosporins are an interesting group of antibiotics because there are different generations, and they've kind of changed slightly in how they what bugs they can be used against depending on what generation they're from. So in general, cephalosporins originally were targeted against gram-positive organisms, and as we've said before, they're beta-lactams. Cefuroxime is widely used. It's a second generation cephalosporin, and the reason it's useful is it's not inhibited by beta-lactamases as the first generation cephalosporins were. So cefuroxime is a very useful antibiotic. When you come on to the third generation cephalosporins, such as cefotaxime and ceftriaxone, they have cover against both gram-positive and gram-negative organisms. And so you now see that when you treat meningitis, for example, a first line will be something like cefotaxime, which you need to cover both gram-positive and gram-negative organisms. Ceftazidime is another third generation, and that has anti-pseudomonal activity, which none of the other cephalosporins listed there do. So that's a little bit of a different group. The issue with cephalosporins, as with penicillins, relates to hypersensitivity reactions, and I'm sure you'll all have read this, but it is definitely true that a small percentage of children who have hypersensitive reaction to penicillin will also be sensitive to cephalosporins. So you need to be very careful if they're allergic to penicillins. You probably wouldn't go to a cephalosporin because there is a chance they will also be hypersensitive, have a hypersensitive reaction to that as well. Aminoglycosides. So aminoglycosides are extremely effective antibiotics. They're one of the group that inhibit protein synthesis, and they do that by binding to the ribosome, and it's the 30S unit of the ribosome. They bind to that, and they stop the protein synthesis, to stop the bacteria being able to produce the protein and therefore being able to replicate. So it's bacteriostatic, not bactericidal. They are very effective against gram-negative organisms, but also have some cover against gram-positives. The problems with aminoglycosides, as you'll be aware of, is that actually they are not very good for your kidneys or for your ears or for your hearing. Most of the problems associated with aminoglycosides probably relate to the high trough level. So if you think you have a peak level after you give the dose and then you drop to the trough level before, it's actually probably not, the peak level is probably not the issue, it's if you have too high a trough level. There have been lots of studies looking at the best way to give aminoglycosides to maximise their efficacy and reduce their toxicity, and the standard practice now is that they should be given in a once-a-day format as opposed to the old days where we'd give them 3 times a day. Okay, and the reason we do that is you give a bigger dose, you get a higher peak concentration, which gives you better killing action against the bacteria, but it doesn't increase toxicity. Okay, so and that actually has now been shown to reduce toxicity, certainly in CF patients. Final slide I'm going to speak to you about is about antifungals, and again this is relatively small print, but there are 3 main groups of antifungal agents. And as we spoke about before, the cell wall in fungi are very different to bacteria, so they don't have the peptidoglycan layer. Instead they have ergosterol and beta-glucan, and they're what's targeted by the antifungal agents. Polyenes such as nystatin and amphotericin bind to the ergosterol in the cell wall, and much like the beta-lactams cause the bacterial cell wall to fall apart, it does a similar thing to the fungi. But obviously it's not affecting the peptidoglycan, it's binding to the ergosterol. Azoles, so fluconazole, itraconazole, voriconazole, posaconazole, are a very effective group, very expensive group of antifungal agents. So fluconazole you would tend to use against Candida, you would use itraconazole and voriconazole against Aspergillus. Again, they work on the ergosterol. Rather than binding to it, they block the synthesis of it. And again, they cause cell wall dysfunction, but through a slightly different way. They're not binding to it, but they're blocking, they're stopping the fungi from synthesizing it. And again, the cell wall then doesn't work, and the organism falls apart. The final group is caspofungin and microfungin, and this is, rather than it being the ergosterol that's the target, it's the beta-glucan, and again it's inhibiting the synthesis of that, and again it's affecting cell wall. So all these agents affect the fungi cell wall in slightly different ways. On that happy note, I'm going to stop, but I'm very happy to take some questions. Thank you very much. Why do we use both ceftriaxone and amoxicillin? Yeah, so the amoxicillin, it covers listeria. Okay, so there is, in theory, you add in amoxicillin purely to cover listeria. Yeah. Yeah, so the amoxicillin is because of listeria, and so it's the risk of listeria which the cephalosporin won't cover. The amoxicillin will cover the listeria, and because listeria, it doesn't tend to be a problem after 3 months of age. That's why we stopped having to use it. I can't remember the last case of listeria in the UK. It was a very long time ago, so there are those that would argue it's not hugely necessary.
No, I think that's the case of listeria meningitis. So in the neonatal period, so it does still occur. So you get it, and it's usually it doesn't really result in that much neurodisability. Also, don't name your children after angels.
Yeah.
But Comox is quite regularly used as a second line for E. coli infection.
Yeah. Because the clavulanic acid inhibits the beta-lactamase. So in the Comox lab, it's the clavulanic acid that enables you to use it against beta-lactam or beta-lactamase producing bacteria. So it's the clavulanic acid in that enables it to target things that you wouldn't normally be able to cover. So that's why it's the difference. It's the clavulanic acid that directly inhibits the
gram-negative bacteria are the ones that usually produce the beta.
Absolutely. They have the beta-lactamase. It's in the gram-negative ones that have that. Yeah, absolutely.
I'm just wondering, is there any particular reason why amoxicillin is the one that could give global effects out of all the penicillins?
So why that causes the rash as opposed... That's a good question. I don't know the answer. Do you know the answer to that, Will?
What was the question?
So why it's amoxicillin that causes the rash in association with glandular fever?
Ampicillin was the classic.
Yeah.
The answer is, I don't think anybody knows, but I do think we make quite commonly transient antibody responses to ampicillin/amoxicillin following a lot of viral infections. So there's a very high false positive rate with immediate testing for antibiotic sensitization. The child that comes up in a rash with a virus and they send to the allergy clinic, you test them immediately, they often have antibodies to antibiotic which make you think they're allergic. They decline over the next few months. It's likely to be a specific antibody to the antibiotic at that time that's being produced. It's cross-reacting. So it's being made to the virus and cross-reacts.
But a paper where it said ampicillin is associated with a rash.
Yes.
Amoxicillin
Is not. Yes, that's right. So it's classically, I know it says amoxicillin in some sources, but ampicillin is the classic description in the literature. But there's also, there are papers that show that you are transiently sensitised to amoxicillin following many normal viral infections in childhood.
And
It complicates allergy testing in the first few weeks after coming from the rash. So you wait before doing testing.
the other issue with that is from a pragmatic point of view, it's the different things that you learn here compared to what you do in practice. And if you've ever given a child penicillin V, you'll know it tastes absolutely disgusting. And trying to take it 4 times a day as opposed to 3 times a day, so certainly from a pragmatic level, we often use amoxicillin because it's not like ampicillin where there was a high risk of it. It's much less so. You know, the guidelines certainly where I work has changed to use amoxicillin as first line for tonsillitis in children because it's much more palatable and it's it's 3 times as opposed to 4 times a day, so you improve adherence. Any other questions?